So I would like to introduce Dr. Tabassum Salam. Dr. Salam is the Medical Director of CareLink Services at Christiana Care. As such, she leads an interprofessional team that provides information technology-enabled intensive care coordination for large patient populations across a broad geographic area. Her team engaged with physicians, practices, hospitals, community agencies, and other providers that deliver healthcare to these populations. She's also the governor of the Delaware chapter of the American College of Physicians, and she will speak about her experience, population health management, improving outcomes of complex patients. So thank you very much, Tabassum, for being here.
Sorry. But you're awake now. Good afternoon. I am so excited to be here. Claudine sent me an email inviting me to present at this conference, and the email came to me while I was on vacation. And I promised my family that I would not respond to email during that vacation, but hers was the only one I had to break the rule for. So thank you very much. Let me tell you a story. Let me tell you about my experience working with a wonderful team over the last few years. I'm going to try and extrapolate that experience to the one you are generating, the one you are living, which is the care of populations of patients who are complex and have longitudinal chronic care needs, patients with CKD. So if you had to develop the population health management program to take care of these patients, this is what I would suggest are the essential ingredients, at least from my experience and where I see it. You really need to identify the risk factors of your population that make them higher risk, identify the team that's taking care of these patients, change the culture of this team, change the processes and operations of all the healthcare delivery sites that take care of this population, enhance your IT and communication infrastructure, just as you heard before lunch from Jenna, and get some analytics opportunities in to really spearhead all of this. So let's talk a little bit about identifying your high-risk patients. I know you might come back and say to me, patients with CKD are all high risk, and I concede you are right. But nonetheless, you can't do everything for everybody unless you have huge resources, and since most of us don't have that, it's good to learn to know how to filter and start with patients who need us or need care coordination the most, and then work outwards. So if you've got a large population of patients like this, it's good to know what factors might be contributing to those who are at higher risk for poor outcomes, poor health outcomes. And this is some of the ways in which I think about it. I think about some clinical factors. I think about the socioeconomic factors that influence our patients' health and behaviors, and then inherent behavioral factors that influence all of that. So the clinical factors, I don't need to reiterate. We all know them very well, and the patients exemplify them every day. Their medical comorbidities, psychiatric comorbidities, their cognitive status or functional status, you know that's all going to factor in. Let's talk a little bit about the socioeconomic factors. Clinicians sometimes need to be reminded about how essential this is to the ultimate clinical outcome of a patient. Where the patient has the privilege to live, the kind of setting they live in, the kind of family support they have, what language they speak or understand, the extent to which they understand informational material you give to them if it's in printed form, their transportation difficulties. You know all of those matter in getting a patient successfully primed to receive the best and take the best of the health care being given to them. And then there's the most nebulous of these factors, their behavioral component. What are the patient's attitudes towards his or her own health? What values do they bring with them from their family and their childhood and their upbringing? And what are their fears about their chronic disease? You've got to meld this all in to figure out where and how to find the patients who truly are at highest risk. And if you've successfully figured all of that out, you could put that all together into an algorithm and try to use that to filter your patient population, again, to target the group that you want to start with and then work outwards. And in some entities, such as ours, we've been lucky to have more automated prediction engines to try and help us, again, slice and dice the large population to find a subgroup to start our interventions on. So once you've got a group in mind, let's talk about the team that it's going to take to care for that patient. So here's the population you've discovered. And from within that group, you find the subgroup who are the groups you're going to focus on first. That patient and his circle of care will go to physicians, providers in various sites, just as we heard from the morning speakers. They will go to hospitals, clinics, dialysis centers, consultants at various different places, not just one hospital or one health system. They will access care from other providers like the 911 system. They will receive care sometimes in their home from home health care agencies. And they will receive support from community agencies as well. As I know you all know very well, this is all disparate. Wouldn't it be great if there would be a way to circle all of this and bring us all together, just like your morning speakers were telling you? So let me tell you a little bit about an experience we have here. We developed a team to try and do that. And our team is called CareLink, and it's the name of a group that provides what we think of as intensive care coordination to patients or populations of our that we're focused on. The CareLink team itself is comprised of nurse care coordinators, a respiratory therapist, social workers and pharmacists, and a medical director, a couple of us actually. And this team fans out on the patient's behalf to interact with all of the other healthcare delivery or access sites that our patients go to. Our patients go to pharmacies, and if there's some hiccup in their receiving their meds, we'll help them negotiate the conversation with the pharmacy. If the patient, as you know, certainly in the CKD population, needs to access care from various different sources or different physician sites or different providers, we try and negotiate that conversation just to make sure the various pockets of care know what the other group is doing. If your patient requires durable medical equipment and is having trouble having that conversation with the supplier to get their equipment restocked or fixed, we try and jump in if they need us to broker that conversation. Next thing we try to do, a program that this needs to do, is really promote a change in culture. So you really do need to have the team engage patients and their circles of care. The CareLink team does a lot of patient education, patient self-management, empowerment, not only of the patient actually, but of their family and their caregivers, their network. Help them understand why it's important to remain adherent to the medications, why it's so essential to get your blood work done as specified, why it's so important to make sure you see your different care providers and how each one has a special contribution to make to your care. We spend a lot of time engaging the physicians who are integral to the care of these patients. As you all know, one primary care physician may not know what the nephrologist is doing, and vice versa. And there's the endocrinologist who manages diabetes. I don't have to tell you that story. But the one constant that CareLink tries to be is the constant for the patient, the one green circle that goes across all of those. So we will have conversations with the various sources of care that a patient goes to try and navigate that. Our pharmacists will call 2 or 3 physicians who are involved in a patient's care, and this could be a classic conversation. Dr. A, you prescribed an ACE inhibitor to this CKD patient, but were you aware that the cardiologist of this patient also has already prescribed an ARB? And were the 2 of you aware that the nephrologist is okay with that, but the dose needs to be adjusted for the CKD? As you know, that conversation is often truncated, or worse still, just never happens because one group doesn't know what the other is doing, or even that the other exists. And another big focus of our energies is engaging the team outside our walls. So as you know, your patients will go to multiple disparate health systems or centers or sites for care. So we try to break those walls and have the communication transcend. Your patients receive care from home healthcare agencies. So we have really spent a lot of time building connections with those groups in our network who care for our patients. So, for example, with one of the home care agencies in this area, the Visiting Nurses Association, we have tried very hard to build up video consultation. So when the nurse from that agency is in the home, she pulls up her laptop and has a video chat from the patient's home with the patient sitting right next to her with the CareLink registered nurse partner, so that it allows everyone to have a sort of face-to-face conversation without physically being face-to-face. Our patients go off to skilled nursing facilities or rehab centers for short stays, which sometimes draw out into longer than we need stays. So again, we have a vigorous conversation network going where we check in very regularly with about 20 of the highest by volume referral sites for post-acute care in our community. So we can constantly keep track of where our patients are going and, again, help them have that conversation with all the various caregivers. And likewise with community agencies who are doing a wonderful work for our patients. All we're trying to do is make sure everyone's aware of what the other is doing so we can have the smoothest trajectory for a patient. Processes and operations obviously need to be looked at, and I know you've talked about this at no end this morning. I like to show this slide. So I think if you ask a group in an industry outside of healthcare to develop a mousetrap, they'll probably come up with this classic. It works, it gets the job done, and it's pretty straightforward. But sometimes when you ask folks in healthcare to develop a mousetrap, they give you this. How many of you know this game? So I can gauge that by the raising of the hands, you either have a child under the age of 10 in your household now or have had one. We had this in our house until I was so frustrated with it because it doesn't work. You're supposed to build these pieces and then drop the marble, and it's supposed to merrily go along the track and plop in the end. It never works. A true story, one night when the kids were asleep, I disappeared the box and took it straight to Goodwill. My point is, so many of our healthcare components, sites of delivery, all well-meaning, but they don't flow seamlessly. So you have to start thinking about how you can break down some of those silos and reach out to the partner before you, that came before you, or is going to come after you, so that your patient is the constant and gets as seamless care as we can make it. Here's an example of what we've tried to do here at Christiana Care. We participate in a bundled payment care initiative, trying to basically streamline care for a patient who's having joint replacement surgery. Here's that example. So we had to work out, how do we put all these pieces together? And a lot of groups got together and broke down walls so that a patient who's having joint replacement surgery, one of the constants is the CareLink team. So we engage them before surgery, when it's a scheduled surgery, start talking to them about what it's going to mean to have surgery, what it's going to mean to recover sensibly and safely from surgery. When they're in the hospital, there's this huge group here in the hospital that does wonderful work with them, and the CareLink team's right there. And then afterwards, what is it going to take to keep them healthy, recover well, make sure they get to therapy, make sure they keep all their other chronic conditions in good check. And there, too, the CareLink team is their constant, helping them navigate all of that. Another component, it's awesome to have IT infrastructure and communication infrastructure. And as you heard from wonderful speakers this morning, we're all aspiring to it, and we'll get there. Let me tell you a little bit about some of the fun tools we have here. So we've been lucky enough over the years here to have our IT team develop some of this for us. And so we are able to get a lot of great data feeds from the Delaware Health Information Network, which is this state's health information exchange, and the CRISP, which is Maryland's, which is also awesome. We're able to get data feeds from claims, from insurers of patient groups that we're taking care of, and from our own hospital systems. And from health records of some of the other partners in the care of the patients that we're taking care of, partners up and down the state, actually, other health systems. And we're aspiring to getting biometric device readings in. That's the next frontier for us. And then I mentioned we use a prediction engine to tell us which are the patients that need our help the most. And we take all these sources of data and populate bits of valuable information into our population health record. And we're also trying to reach out to patients through a member portal. So what does this really mean? This is one of the greatest things that we work with every day, which is we get alerted or sort of pings from the Health Information Exchange when one of the patients that we're taking care of has an admission to any of the hospitals or emergency departments that report to the Health Information Exchange. And it's really great in real time to get a notification. Here is a fictional patient, Perry Mason, has had an admission at the Bay Health Medical Center down in Dover. But we're in charge of trying to help this patient. So regardless of where he's gone for his care up and down the state, when we know this, we can be proactive. When we get these pings, we can call down to the ED at Bay Health and say, how's this patient? We're taking care of him. What kind of information can we give you? He's got this robust care coordination team behind him, and he's got all these docs and other providers. It basically, again, trying in real time to smooth the trajectory for this patient. Another great asset from this IT enhancement is we get lab notifications from any of the labs that report to the Delaware Health Information Network. So if one of our patients with CKD also happens to have diabetes and it's not in good control, and he or she gets his A1C drawn at a community lab, we will get this ping, this trigger. And that'll trigger us to call the patient, say, we see we had this lab drawn. It wasn't so, you're not in good control. What are we doing about it? Do you have your follow-up appointment with the PCP to discuss this? And in case the answer is no, then our next statement is, how can we help you get that going? Do you need transportation to it? What's the barrier? Why haven't you made that appointment? And how can we help remove that barrier for you? But it's so much of a privilege to get these kinds of triggers in real time because you can enact change in real time. And the final component is it's nice to take a step back sometimes when you have populations that number in the tens or hundreds of thousands, to be able to step back and just look at your whole population in a big view, again, to filter and slice and dice. But it's also nice to go down to a very granular level. We are on the cusp of getting information at this detail about our patients of interest, where this is shows you this patient who happens to have chronic kidney disease as well as several other conditions. This is a global view of all the various places he has received care. Now, until we had a view as global as this, if I was this provider who had a visit with him in January, I wouldn't know that there were all these other visits. Sometimes these are with other care providers. Or if I saw him here, sometimes I didn't realize that there was a 3-month hospital stay here. It's so nice to get this global one-shot view and then use it to enable the conversation with the patient and all the people who care for him. So just to give you some tidbits of how we're progressing and using those enhancements, I mentioned our bundled payments program. Here's some of our first results. And one of the measures we focus on very much is decreasing readmission rates. Because one way to think about it is, if your patient is doing well after having surgery and recovering as you hope, one would think they would not need to go back to the hospital. None of us wants them to. So we've been watching very carefully to see and make sure that our readmission rates are dropping. And it's really gratifying to see that they are down and they're staying down from our baseline before all of those changes are put in place. So as you can see, our 7-day readmit rate has dropped by 15%, and the 30 and 90-day readmit rates are above 20% and holding. Another subgroup that we started our work on is the congestive heart failure group. There too, with a big focus on readmission reduction, again, as a sort of proxy measure for better health after leaving the hospital. It's in that they're doing well enough to not have to go back within 7, 30, or 90 days. And there too, we've been happy to see a drop. that sustained over 90 days and has been sustained over the months since we started working with this group. So the bottom line is we're all here today to talk about moving the needle from reacting to acute illness in our patients with CKD, but really to looking to give them more disease management and support, looking at the big longitudinal picture. And what you really want to do is get to a state where they achieve good health, good stable health, and one of the components, I think, is complex care coordination. We're really trying to utilize and maximize what we think we can do with that to get our patients healthier.